Today's ICD-10-PCS coding case study focuses on what you need to know when coding a 360-degree spinal fusion. My name is Claire and I'm an inpatient coding auditor. In my quick tips and tricks videos, you'll discover valuable insights to help sharpen your medical coding skills and code with confidence. If that sounds like something that would be helpful to you, please consider hitting that subscribe button so that you can be notified whenever I release new content. In ICD-10-PCS, spinal fusions are classified under the root operation fusion, which is defined as joining together portions of an articular body part, rendering the articular body part immobile. The goal of a spinal fusion is to join together two or more vertebrae of the spine, allowing them to heal in a single solid bone. The procedure is done to stop painful motion or restore stability to the spine. According to PCS guidelines, a spinal fusion requires the use of bone graft or a bone graft substitute to make the joint immobile. This means that the operative report must describe the use of bone graft or a bone graft substitute to code the procedure to root operation fusion. It's important to note that this guideline is specific to spinal fusion and does not apply to fusion of other joints. When you're coding a spinal fusion, there are a few key pieces of information you'll need to gather from the operative report. You need to determine the level of the spine that was fused and how many vertebral joints were involved. Additionally, you'll need to determine whether the fusion was done on the anterior column, which is towards the front of the body, or the posterior column, which is towards the back of the body. When both the anterior and posterior portions of the spine are fused, this is sometimes referred to as a 360-degree fusion. If both the anterior and posterior columns are fused, it's important to report the PCS codes for both procedures. You'll also want to determine the technique used to access the portion of the spine that's being fused, whether it was an anterior approach from the front or a posterior approach from the back. And finally, you'll need to determine the type of device used, whether that be an interbody device or a type of bone graft material, as well as any additional procedures performed, such as a discectomy or a decompression. The 360-degree spinal fusion is one of the most confusing procedures for a lot of coders, but once you understand the anatomy of the spine, determining which side was fused is much easier. The shape and structure of the vertebrae are very different in the anterior portion of the spine versus the posterior portion of the spine. The anterior portion of the vertebrae is round and smooth and is called the vertebral body. Between each vertebral body is an intervertebral disc. Each disc forms a cartilaginous joint to allow movement of the vertebrae and acts as a ligament to hold the vertebrae together. The posterior or back of the vertebrae has three bony protrusions. In the middle is a spinous process that resembles a dorsal fin. Attached to that is the lamina. Bilaterally, the lamina are surrounded by pedicle and facet joints. There are some terms that you can look for in the op report for clues as to whether the fusion was of the anterior or posterior spine. Documentation clues that indicate the fusion is being performed on the anterior spine include anterior, interbody, because the use of an interbody fusion device will always indicate fusion of the anterior spine, intervertebral disc, vertebral body, annulus fibrosus, and nucleus. Documentation clues that indicate that the fusion is being performed on the posterior spine include posterior lateral, pedicle, transverse process, spinous process, lamina, and facet. When coding from an operative report that describes a 360-degree fusion, it's not uncommon for coders to sometimes code only the anterior fusion and miss coding the posterior fusion. In order to avoid making this mistake, it is important to understand that when coding a 360-degree fusion procedure, a minimum of 2 codes are necessary. One code is needed for the fusion of the anterior spine, and another code is required for the fusion of the posterior spine. Depending on the approach, number of levels fused, and the devices used, multiple codes may be necessary to accurately capture the procedure. This multiple coding is supported by the PCS guideline for fusion procedures of the spine that states if multiple vertebral joints are fused, a separate procedure is coded for each vertebral joint that uses a different device and/or qualifier. When coding a 360-degree fusion, you'll need to determine the approach that was used to access the spine. One of the best ways to do this is by determining how the patient was positioned during the procedure. The spine can be accessed through either an anterior approach, which involves entering through the front of the body with the patient lying supine, meaning face up, or a posterior approach where the entry is made through the back of the body with the patient positioned prone, meaning face down. Additional documentation clues to look for include mentions of elevating the platysma or dividing the strap muscles for an anterior approach, and access via hemilaminectomy, facetectomy, foraminotomy, or laminectomy for a posterior approach. Also be aware that a 360-degree fusion may be performed through a single incision or via 2 incisions. When done via 2 incisions, there would be an anterior incision for the anterior spine fusion, followed by physically turning the patient over and then performing a posterior incision for the posterior spine fusion. Let's review an operative report that describes a 360-degree fusion. First, I'm going to do a quick review of the complete op report, and then I'll break it down to the specific documentation that helps us build our PCS codes. The patient was brought to the operating room and administered anesthesia. They were positioned prone, prepped and draped, and an incision was made over the L4-5 level. Dissection was continued down to the L4 and L5 transverse processes, which were exposed and decorticated. Attention was turned to performing a transforaminal lumbar interbody fusion. A complete discectomy was carried out, and an interbody fusion device along with demineralized bone matrix was inserted into the disc space. On completion of this, attention was turned to performing the posterior fusion and instrumentation. Pedicle screws were placed, and the posterior lateral fusion was carried out by decorticating the transverse processes of L4 and L5, followed by packing a combination of DBM, auto, and allograft combined with infuse over the transverse processes. This completed the posterior lateral fusion. Closure was then done, and the procedure was complete. Now let's review the operative report to determine which part of the spine was fused. Starting by identifying clues that indicate the fusion of the anterior portion, I've highlighted in yellow the documentation clues that indicate fusion of the anterior portion of the spine. The physician specified that the procedure was an interbody fusion. The use of an interbody fusion device always indicates fusion of the anterior spine. Additional clues include documentation of the procedure involving the intervertebral disc, which is a component of the anterior spine. The physician also detailed insertion of an interbody cage into the disc space, confirming that the procedure fused the anterior spine. Moving on to documentation clues that indicate the fusion of the posterior portion of the spine, I've highlighted in green the documentation clues that indicate fusion of the posterior spine. The physician specified that the procedure was a posterior lateral arthrodesis, indicating their intention to fuse the posterior portion of the spine. They described the placement of pedicle screws and the completion of the posterior lateral fusion by using a combination of DBM, auto, and allograft with infuse over the transverse process, which is a component of the posterior spine. This description of placing bone graft over the transverse process confirms that the procedure fused the posterior spine. After confirming the fusion of both the anterior and posterior spine, we know that we'll need at least 2 codes to capture this procedure. However, we do still need to determine the approach, fusion device used, number of levels fused, and any additional procedures that may have been performed. Next, let's determine the approach to the spine for this procedure. I've highlighted the applicable documentation in turquoise. In this case, the operative report describes that the patient was positioned prone and that the incision was made over the lumbar level, indicating that the approach for this procedure was through the back, and so a posterior approach to the spine. Next, let's identify the devices that were used. I indicated the applicable documentation with red font. The operative report specifies that an interbody fusion device along with bone matrix was used for the anterior fusion procedure. According to PCS guidelines, if an interbody fusion device is used to render the joint immobile containing bone graft or bone graft substitute, the procedure is coded with device value interbody fusion device. For the posterior spine fusion, the op report indicates that the fusion was carried out by packing a combination of DBM, auto, and allograft combined with infuse over the transverse process. According to PCS guidelines, when a mixture of autologous or non-autologous bone graft with or without biologic or synthetic extenders or binders is used to immobilize the joint, the procedure should be coded with the device value autologous tissue substitute. Now to determine the spinal level fused. I indicated the applicable documentation with purple font. The op report indicates a lumbar fusion of L4 through L5. It's important to understand that a level consists of two vertebrae and the inner space that contains the disc. In ICD-10-PCS coding system, a vertebral joint is defined as two adjacent vertebrae separated by an inner space. So when determining the levels, we need to count the number of vertebral joints between each level rather than counting each level individually. This means that L4 through L5 is one joint, making it a single lumbar level for our fusion procedure. Now we have all the information needed for our two fusion codes, with the final codes assigned being for fusion of lumbar vertebral joint with interbody fusion device, posterior approach, anterior column, open approach, and fusion of lumbar vertebral joint with autologous tissue substitute, posterior approach, posterior column, open approach. Last, we need to review if any associated procedures were performed, and in this case, as you can see highlighted in magenta, a complete discectomy was performed, so we will assign an additional code for resection of lumbar vertebral disc open approach. So that's it for today's procedure coding case study. I really hope that this video was helpful for you. If it was, please give it a thumbs up, and if there's any procedures that you'd like me to cover in the future, just leave a comment below and I'll add them to my list. Thanks for watching, and until next time, happy coding!